Hi everyone, it's Kelly from the Hub. I am here with Stacy Ettinger of the WellSpan Ephrata Community Hospital. I have to make sure I say all those words. She is the stroke coordinator, which means when you have a stroke and you go into the hospital at WellSpan, she will, if not see you, she will know about you and be able to talk about all those kinds of things. So we are here today to talk about strokes because that might be something that's not on your mind, but with all the COVID-19 stuff going on out there, we should be talking about what that means. So hello, Stacy, how are you?
Hello, Kelly. It's nice to see you again.
It's nice to see you. So let's talk about this. So take us from the top. If you have a stroke and it's now, what should you do?
So one of the things that we found out nationally across the United States, there's two things with COVID going on. So everybody's afraid to come to the hospital right now. Everybody's afraid that the hospitals are, dens of infection and those kinds of things. First of all, I want to assure everybody that that's not true. I have never been more proud of WellSpan Ephrata Community Hospital than during this time. They have taken just the most top-notch infection control schemes and protocols and made them work. We are collaborating with both Mayo Clinic and Johns Hopkins to follow their protocols. So things have been excellent here.
Good. That's very impressive. I mean,
yeah, it has
just
been.
to toss around the names of Mayo Clinic and Johns Hopkins in the same
Correct.
sentence, pretty impressive. So good. So go to the hospital, everybody, right? Go to the hospital. Okay.
So this is what we're seeing across the United States is we're seeing people with MI or heart attack, strokes, even heart failure where they have shortness of breath are not coming to the hospital because they're afraid they're going to get COVID while they're in the hospital. And this is particularly disturbing to those of us that take care of heart attack or stroke patients, but especially stroke patients. So
what's unique about stroke that makes this so important? I mean, yes, strokes are important, but what's unique about this?
The fact is that the infection actually is causing young people to have strokes, very large strokes. The fact is that nowadays, and a lot of people still don't know this, we have really good treatments for strokes, but they're very, very time limited and you need to get to the hospital right away. If you don't get to the hospital, the reality is that you could be impaired for the rest of your life.
Okay, so that takes us to the place that we need to talk about. How do you know if you're with somebody or yourself? How do you know that you might be having a stroke? Because it's not like, somebody's like, you're probably having a stroke. Like, how do you know if it's yourself?
So a lot of times patients do know they're having a stroke. Family members know they're having a stroke. The thing that we tell people to remember is the mnemonic or the abbreviation for be fast. So be fast means be fast and get to the hospital. And B stands for bounce. So if you're walking around and you haven't been drinking and all of a sudden you're very off balance and kind of staggering around, it's very probable that you're having a stroke. Now, that isn't something that we've been talking about for years, but we are talking about it now. And actually, that means that you're probably having a stroke in this part of your brain, in the back of your brain.
Ah, good.
Yeah. E stands for eyes. So if you lose vision in one eye or the other all of a sudden, or if you're seeing double, especially seeing double, that is always a stroke, okay? And if you notice, both of these things so far that I'm talking about, it's all of a sudden. It's not like it just came on, you woke up one day and you felt a little bad or a little weird, and then the next day you felt worse. And then the third day, all of a sudden, you have this blindness, or the blindness came on slowly. That's not a stroke. A stroke is always all of a sudden. Then we have fast, and fast is the traditional thing that we've been teaching people for about 10 to 15 years. And it also means get to the hospital, but it generally means that you're having a stroke on this parts of your brain. So F is for face, and this is the thing that patients themselves don't recognize. It's usually a family member that recognizes it. People can have such bad facial droop that they can't control the saliva in their face, and they themselves don't recognize it. But hopefully somebody will look at them and see that something is off.
And you might be able
So,
to tell if you ask someone to smile, right?
correct. So
Good.
again, when you come to the F things, you draw a line down your body. It's one side of your body, the other. It's not both, and it's all of a sudden. So F is for face, and face can mean your face is drooping, or your face is, it even can be your face just being numb, like whole side of your face being numb. And, or if you, I'm going to try to do it.
It's
If
hard
you're,
if you can't, yeah.
it's like, if you're smiling like this.
Ah,
So if your smile is off and you can't smile on both sides. But sometimes people are drooping so badly that they are starting to drool.
wow. All right, so that's the F is for your face. So that's how you
Right.
can check it. All right, what's the A?
The A is for arms. It's really for legs too, but it's more for arms. So what we will ask you to do in the hospital is to hold your arms up like this, like a big pizza pie, and count to 10. And we're looking to see, sometimes it's not as overt as you think it is. We're looking to see for your hand to drop. So it can be just a little bit of weakness. But if we see that, and that's another reason why it's important, because we are doing a neurologic exam that we have been very highly trained to do. So arm means either your arm is heavy, it's weak, it's numb, or it's totally paralyzed and you can't move it whatsoever.
So if you even try to put your arms up and one of your arms doesn't go up, that's also
That's
part of
bad.
it. Okay, that's bad. Okay.
That means that that is a very bad stroke.
All right.
Okay.
So face, arms, S.
S is for speech. And this is the one that encompasses a lot of different things, because people think for most of us, your speech center is on the left side of your head. But there's not just one, there's actually two of them. The first one controls how you mechanically make speech. It's called Broca's area. And what it does is is, like I said, it's mechanical. So if people have a stroke in that part of their brain, they will have slurred speech, or they can't produce any speech at all because their vocal cords can't move, or they're kind of stuttering in their speech. They're really trying. And then there's another part of your brain back here called Wernicke's. And Wernicke's is about language. So if somebody all of a sudden sounds like they're not making sense, they can't put sentences together, they're reaching for words, they're more likely to have Wernicke's. But so basically what I'm saying is that speech can be expressive aphasia, which means you know what you want to say in your brain, but you can't get it out. It could be dysarthria, which sounds like he's drunk a 6-pack of beer in an hour and you're slurring your words.
Which is funny, except when it's a stroke, right?
Right. It can be Wernicke's aphasia, where it's a bunch of gobbledygook together and word salad, and just to make any sense. And last but not least, the one that I did not talk about is what we call receptive aphasia, which is very important for patients to get to the hospital and treated, meaning that they can understand you. They can't, I'm sorry. You can understand them and their speech makes sense and their speech is most likely clear, but they can't understand you. So that they have lost the ability to understand speech.
Oh.
Yeah, it's really not a good thing. So a lot of times families will bring patients to the hospital thinking that they're confused, but what we see in the hospital is more, they think their family is speaking a foreign language all of a sudden. They sometimes are very angry because they think their family is pranking them because they can't understand them. But they will say to us again and again and again, "What's going on? I can't understand you. What are you talking about?" So it's very important to get patients to, because a lot of times patients will have that symptom and they won't have any other symptom, but we certainly need to treat them emergently to get rid of that. So,
Especially if this is a older child with their older parent, they're thinking their parent has dementia.
right. And all of a sudden, and people don't develop dementia all of a sudden.
Right. But
It's
those are
a
all the
slow
things,
thing.
right.
Right.
Those are all the things we see in movies and TV. And so we think, oh, well, look, see, mom has dementia now. She really had a stroke. Aha. Oh, this is so good to know. Okay. So we did face, arms, all the speech stuff. And so what's T?
So T is for time. So every minute during a stroke, you are losing 1.9 million neurons. And so there's two different things that we do to treat stroke patients. And I think we're going to talk about this in another session, but I'm going to tell you real quick.
Good.
So the first thing is that, which applies to anybody who's not on Pradaxa, Xarelto, or Eliquis, is that, and who gets to the hospital in less than 3.5 hours. What that means is that we give you TPA. Now, TPA is a very, very powerful clot buster. And if you would take a Petri dish or a dish and put a big blood clot in the middle of it and drip TPA on it, after 2 or 3 drops, that clot would go away. It's definitely, that's why we call it the clot buster. So it's an amazing drug, and I never saw anybody have TPA till I was a nurse for 20 years. And I thought it was pretty miraculous, and 10 years later, I still think it's miraculous.
So you can actually, if you give someone TPA within that window, it can stop-ish what's happening.
It can only stop-ish, it can undo it. So it happens a lot of times, not every single time. It has a 36% efficacy. And the quicker you get into the hospital, from the time your symptoms started, the greater that efficacy gets. But the average in the time we can give it is 36%. So we have patients that come into the hospital and have had very severe strokes. They're totally paralyzed on one side. They can't speak at all. They start losing their consciousness, all kinds of things. And they just look really bad and really, really sad. And like they're going to die. And we give them TPA, and literally immediately after we give them the TPA, they sit up in the bed and look around and say, what's going on?
Wow. Wow.
It's honestly, as a nurse, it's one of the most beautiful things that I've ever experienced. Now, again, I am going to say that it doesn't help every single person in the world.
Right.
But it does help in 36% of people. There is a small risk of having a bleed with it, about 5%. The literature actually says 6.4%, and that's what we'll go with, is 6.4%. But you have a 94% chance of it not doing that and helping you. And we leave that decision up to patients. We don't say we're going to give you TPA. We ask you whether or not you want it. There's another treatment. It can't be done for every single person, but it can be done for those very, very bad strokes. So this is very exciting. And it's called a mechanical thrombectomy, or sometimes you're going to hear it called an endovascular intervention. We have a lot of names for it. But that can be done up to 24 hours after having a stroke. And we've only known this for about the last 3 years. I was privileged enough to be sitting in the International Stroke Conference when they announced that we had a new treatment for stroke, and it was up to 24 hours. And it was just so exciting, and to see patients after they have it. Now, we do not do this at Ephrata. We do this at York, our sister hospital, which is our comprehensive center. And the neurosurgeon there does that, and he's very good. And what they do is they have a stent, a wire, just like they have for when you have a stent put in your heart, except for they're going to put the stent in your brain. You're not going to stay with there. So they will look and see where the clot is in your brain, and they will take the wire and they will thread it up past your heart, past into your neck and into your brain to where the clot is. And then they will deploy a stent, which looks like a bunch of chicken wire together. It looks like curled up chicken wire.
Yeah.
And they leave it there for a little while. And why they leave it there is the clot gets all inside that chicken wire, and then they slowly pull the clot out. Now, this has actually been proven to be more effective and safer, surprisingly, than TPI. However, if it's me or my family and we do and it is considered gold standard treatment, is what we'd like is for patients to have both. We'd like the patients to have TPA plus a thrombectomy afterwards. So I know a lot of patients don't want to go to York. It's outside where their family is, and it's a little while away and everything. And I understand that. I have older parents, and my father has to go to the city for some things, and he's not really crazy about it. But this is not your average thing. This is the difference between you, maybe needing to go to a nursing home or have family members take care of you for the rest of your life, and the chance of having normal life afterwards. So we cannot do that on everyone. Not everybody qualifies for it. It happens to be where the clots in your head are, and we don't know it until then. But we definitely, even in that 24-hour period, the quicker you get to the hospital, the better. We don't want you to call your neighbor. A lot of times we get patients from doctor's offices. We've had patients come from the rheumatologist office, from urgent care, from all kinds of things. We want you to come to the hospital. Nobody, if you don't know if you're having a stroke or not, we don't care. Nobody's going to make fun of you, or your insurance isn't going to get charged, and then you're going to have money afterwards you're going to have to pay. Stroke doesn't work like that. The United States government really wants you to get stroke treatment. So, it's pretty important. Please come. We want you to be wrong, but please come.
That's awesome. I got to tell you, every time I talk to somebody from WellSpan, no matter what discipline it is, I learn amazing things. So this is great. This is great. We're going to be talking with Stacy for several times about all the different other kinds of things that are associated with stroke, rehab, and other things that can go wrong, and bleeds, and other kinds of treatments, and all that kind of stuff. So you'll be seeing a lot of this face over here, and that's a good thing. So bye for now, everybody. We'll see you again. See you, Stacy.
Bye-bye. Take care.